Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
We hear so much about Alzheimer's and other kinds of dementia, and it's very important that we find a real qualified, highly qualified physician who works in this field. And we have, and that is Dr. Tuchman. It's really a pleasure to have Dr. Michael Tuchman, who is director of Palm Beach Neurological Center. And I want to welcome you to the show, Dr. Tuchman.
Thank you so much. Thanks for having me. It's a pleasure to join you.
Yes, and so many people are struggling with this, not so much for themselves, but for their family members. So we talk about dementia, we talk about Alzheimer's, but you specifically are working on dementia with Lewy bodies. What is it, and why is it so hard to diagnose?
You bet. So we actually see all types of dementias because that's what we do here in our center. But dementia with Lewy body is a unique condition. It's very difficult to diagnose, and there are a few reasons. So let's think about them for a minute. First of all, I think it's important for the audience to understand what do we mean by dementia. Dementia is really the development of mental and memory problems as we get older. Now, the reality is that we all come into this with hopefully a healthy brain, and then something happens. All dementias have a neurodegenerative component. So slowly, brain cells begin to die. It could take 10, 20 years for it to develop clinically. The most common dementia in the U.S. is Alzheimer's disease. But second or third to that is this condition called dementia with Lewy body. What makes it unique in our experience in medicine is that it seems to have some features of Parkinson's disease, some features of what the layman would identify as Alzheimer's disease, and yet it's a completely separate entity in which certain proteins are deposited in the brain, throughout the brain of these patients. They're called Lewy body, and that's what gives the disease its name. We can see it under the microscope, and it causes a very specific but difficult to pinpoint syndrome, which includes some behavioral problems. Patients can become combative. They can become irritable. They hallucinate, typically visual hallucinations. They sleep very poorly. They have frequent nightmares. Then they also develop some memory problems, not as severe as Alzheimer's, but they do develop memory problems. And they have motor problems, tremors, rigidity, which they share with the Parkinson's patients.
So it is hard. I can see how you have to separate each one of these, and so the common symptoms of the disease, as you just said, but can they have all of this, or are they just going to have one or another?
That's a great question. So frequently the patients have some component of it, but not all of it. So frequently the patient or their family will report that the patient is changing their personality. They become perhaps more irritable, perhaps somewhat aloof. They develop and they then may well have visual hallucinations, obviously something they never had before. And then they have this bit of a tremor. So the answer is some of it. Rarely do we see it all. And then the issue is, how do we know that that's really dementia with Lewy body? There's no blood test for this. So we need to follow the patient frequently for months. Even specialists like us take a few months to be certain, because we want to make sure this is not Alzheimer's disease, that it is not traditional Parkinson's disease. It is this other syndrome that we're getting to see more and more that shares some of the features of the dementia of Alzheimer's and some of the features of Parkinson's. And it's a little bit of each, but not always the full picture.
So people listening to our show, of course, are going to say, that happens to me sometimes. That's mine. So now what has to happen is, I guess they have to call your office. What would you recommend to our audience for the next steps if they think they have the disease? Now, that's always
That's a very good question, and it's a tough one for us, too. We have to be very careful to be somewhere between alarming the healthy versus ignoring the sick. And we need to find that happy medium, which we're trying to do. Programs like yours are going to get that done for us. So if a patient or the patient's family notices that there's a persistent change in personality, not a day or two, persistent for months, that they begin to have a tremor that won't go away, especially unilateral, one side only. If they also have changes in their sleep pattern, so they go from having normal sleep to being rambunctious, even violent in sleep. We hear patients, families who says, we had to stop sleeping in the same room because he would just, in the middle of the night, while asleep, rear back and hit. He didn't mean to. He didn't know he was doing it, but it was dangerous for me. You hear that story, something is going on.
Oh, wow. Well, that really does cause some confusion, and I'm thinking about that. So, and as we're talking, and I thought I'd just throw this in, Robin Williams, who we all dearly loved, and when we found out he committed suicide the way he did, we couldn't believe it. And now you and I were speaking about that, and I guess he thought, or he knew he thought, some Parkinson's. What did he have, really?
It turned out, and this was a surprise to many of us in the field, turned out that Robin Williams had dementia with Lewy body. So he had this syndrome we're studying. He actually had evidence, apparently, because I didn't take care of him, but I've read about this, of some Parkinson's, a little tremor, a little rigidity, and the behavioral changes. Now, this is interesting, and we're speculating, and it's not we need to be very careful to be respectful. But frequently, patients with dementia with Lewy body are more prone to depression, and their irrational behavior may lead them to suicide. So either Mr. Williams committed suicide because he decided he didn't want to live like that, or the disease itself led him to think irrationally.
Yeah, that's right. It's hard to know, of course, once this has happened and he was not your patient. But I guess you see similarities. And as you have a patient, what actually, since you're involved in a clinical trial for the dementia with Lewy bodies, well, tell us about this and what happens if you accept someone into your trial?
Absolutely. First of all, the fact that we're doing a study on dementia with Lewy body is very exciting to us in the field because we never had anything to offer these patients. In fact, in all my Alzheimer's trials, and we do a lot of those, one of the first things we do is make sure the patient doesn't have dementia with Lewy body because they're not allowed to enter those trials. So now, for the first time in my clinical experience, I've been doing this over 30 years, we have a medication that we've been asked to try on patients specifically who have this dementia with Lewy body. The medication is novel, it's very interesting, and it seems to increase the amount of a chemical that's missing in the brain of these patients. The chemical is called acetylcholine, and it's a neurotransmitter. So what do neurotransmitters do? They allow one brain cell to talk to another brain cell. If it's missing, clearly we're going to have a problem. Well, this particular compound that we're studying is been shown to do this both in healthy volunteers and in animal trials, that it increases this missing chemical in the brains of my dementia with Lewy body patients. So what would a patient do and their family? If they're interested, they would contact us. We'll talk about the numbers in a minute. They would contact us, and we would evaluate to make sure indeed that's what's wrong with the patient, that they have this syndrome. We would then evaluate them to make sure they're healthy and have no other difficulties. We go through blood tests, things like that. And then the patient is assigned to either the medication that we're trying to test or a placebo. Let's call it a dummy pill. Most patients actually wind up getting the actual compound. It's what we call double blind. Double blind means that neither our staff nor the patient knows which group they're in at the beginning, right? They just receive one little pill every day. There are no infusions, there's no injections, nothing like that. And then we follow these patients very, very carefully for months to see if they are responding, if their behavior improves, their memory improves, their movement improves, or not. And again, keep in mind, we are also blind to what they're receiving. That's the only way science works, so that we're not going to be biased by expectations. And after several months, the study is completed, and then most patients may have the opportunity to enter a separate study for ongoing evaluation.
That's very wonderful that this has happened. We've all been holding our breath on dementia now. I think I've been doing this as a gerontologist probably for about 25 years. And, of course, it was always, that people are forgetful, and it was never, ever known what people had. And now it was always said, okay, this person had Alzheimer's, even without proof, and they just threw that word around. And then we hear about dementia with Lewy bodies, and you're right. For an organization, for you to have a grant so that people don't have to pay for this test is phenomenal. And I want to give everybody a phone number. If you feel that everything that Dr. Tuchman has been talking about, maybe you can go and be part of the clinical trial. This is their phone number. Remember, this is Pencil Talk Radio. The phone number is 561-282-5546. And I'll give that to you again. That's 561-282-5546. And I have been in clinical trials before. They're painless. They're absolutely very interesting because I do them, so I think I could be helping society. And so if you're feeling this way, you may find out that you don't have this, right?
Exactly. And that's one of the beauties of this, that we're able to evaluate the patients, find out if indeed that's the case or not, and hopefully if they do belong in the trial, help them to get in there, and if they don't belong in the trial, guide them to what they do need.
Yes, and you are a neurologist. That's very important that we talk about that. So what made you get into this field so specific and not just be a general neurologist?
Well, that's a good question for me. I actually began my professional career as a psychiatrist. I practiced psychiatry for several years and then went back to school and did a neurology residency. I was always interested in the overlap between behavior and the brain. And there's almost no better place to study that than in dementias. In how the heck does the brain fail so specifically that memory begins to give you trouble, that behavior changes, even though we still are walking, we still are seeing, we still have reasonable strength. That's a unique human problem. We don't see this in animals. It's one of the unfortunate components of the highly developed cerebrum or cortex of the brain that it can't fail like this. And it's our job, I think, to figure out what are we going to do to make this better.
Oh, I'd love to hear that. You say that. So your great dream, and hopefully you'll win the Nobel Prize to be able to figure out what we're going to do about this.
Wouldn't that be great? Yeah.
Right?
Forget the Nobel Prize. Imagine how wonderful it will be to be able to really begin to do something about this. When you and I trained, I don't mind saying this, I've been doing this for a long time, we thought it was normal for memory to fail when we got older. That's what you expected. We now know, no, that's not true. When memory fails, when behavior changes, the brain is sick, and something specific is happening. It's our job to figure it out.
Yes, and the brain has taken on such now a strong focus. For so many years, it was the heart, and it was the lungs, it was everything else, but not the brain. It was one of those things, as you said, when it goes, and that's it. But now, of course, being a psychiatrist, I didn't realize that. What a wonderful combination to be a psychiatrist and a neurologist to work in this field. So do you expect that we're going to, I know you want this particular medication that you're testing to be the answer, but do you expect that we're going to find something for Alzheimer's as well as the dementia with Lewy bodies?
I think we will find many things that will work. I think that a decade from now, neurologists are going to be behaving like oncologists do now. They have a cocktail of treatments that cure some cancers or stabilize others. That's what we're going to be doing. We're going to, and I predict this, I think it's reasonable, we're going to be coming up with treatments that delay the expression of the diseases, treatments that treat the front end of the disease, and then treatments that ameliorate the symptoms once the disease does declare itself. So this one here we're doing on dementia with Lewy body, this is a fascinating compound, but I see it as part of a large process and not the answer, if you will. Okay?
Are there other physicians around the country doing the same trials?
Yes, we have, if I'm not mistaken, there's about 30 centers. I could be wrong on the number, but about 30-some centers in the U.S. and others in Europe. So this is an international study. This is very exciting. You got to realize we didn't expect anything like this soon. So this is very good.
Yeah, it is. So let me give everyone the phone number. Remember, I told you Pencil Talk Radio means you write down what you hear, then you'll have it right there. The phone number to call to see if you can participate in the clinical trial is 561-282-5546. Do not be afraid of this. They're not going to do anything to hurt you. Clinical trials are really great ways for you to participate in science. And so and especially if you think you have anything like this, wouldn't it be great for you to feel better and maybe have some improvement? So I'm talking with Dr. Michael Tuchman, who is medical director of the Palm Beach Neurological Center. And this is very important. We're talking about the patients. Let's talk about the caregivers. Since it's a particularly difficult disease, caregivers are kind of doing the best they can. So what advice would you give them?
This is conceivably even harder on the caregiver than on the patient. And that's hard to believe, but believe it, it's true. To be married to someone for 10, 20, 30 years, or to be the child of someone for 40 years, and to have that patient change. So now they look the same, but they're not really the same person anymore. Their personality has changed. They're intolerant or irritable. They're unpredictable. They fail to listen to good advice. They wander at night. They hallucinate. This is a very difficult thing to manage. Our society is not geared to do that. Many, many years ago, when we lived in large family groups in which we had aunts and uncles and cousins and everybody in the neighborhood helping out, we could take turns. But here in Florida, what I find is someone has moved from up north, they moved down here, it's the husband and wife, and one of them gets sick, and there's no meaningful support system. And you need it for a condition like this. So my advice is, one, get a good diagnosis. Two, join a support group, and we have plenty of organizations here in South Florida that are geared to help the caregiver. Because if the caregiver fails or burns out, that patient has become institutionalized. So keeping the caregiver healthy keeps the patient in society.
That's excellent advice, and I'm sure, just talking with you now, knowing you have a very sensitive, kind side to you, I can always tell through the radio waves. So I'm sure that when you have a diagnosis and you're talking to the family members, you help them to understand what's going to happen.
We try very hard, and we also tell them that this is a long-term relationship. We can't manage these patients in one or two visits, and we can't expect the caregiver to even get the concept in one or two visits. So we do have a process. We have nurse practitioners. We have nurse clinicians. We need to do that. They also need to have access to counselors, which we try to get them engaged with. But it's an education. I mean, what we're conversing about here, without the emotional stress of it being one of our family members that we're talking about, is difficult enough. But when we're talking about my wife is having this, or my dad is having this, then the emotion of that of that problem makes the conversation even harder to understand for the caregiver. So we need to take our time and gently bring him to where they need to be.
Yes, that's true. And the biggest problem that people have, once they don't realize it themselves, maybe they do in the back of their mind that they have something that's not working, things have changed, but their caregivers the first thing they try to do is have them give up their car. Yes. That is the worst thing that you can do.
And, especially in South Florida, where a car is our only means of independence. It's not like we're someplace where there's great public transportation. So no car means you're stuck. and it's a huge problem. Unfortunately, as you know, eventually the time comes for that, and that's a very difficult process when we have to indeed take that privilege away. But at the beginning, there's no need. At the beginning, there's usually no need for that.
Well, the one thing that you as a physician, I would urge you to write out a prescription for them. Please give your card to someone else, because an adult child or someone else, a spouse member, can't do it. But they listen to what a doctor says. So I hope that you will do this.
I agree with you. And frequently we're asked to take that role, and that's an appropriate role at the right time. It is an appropriate role. And actually down here in South Florida, there are facilities where we can actually get the patient's driving capabilities assessed, which makes the decision easier for everyone as well. So
yes, that's excellent. My husband's 93, and he's quite sharp on everything, but I didn't think he should still be driving a car, so I found him a driver. Found someone takes him anywhere he wants. He goes to meetings, whatever he does. So there are ways to do this, but I was thinking as you were talking, there are many things that are tough. The other thing, of course, is some people who do live alone shouldn't be living alone anymore, and that's the other danger.
That's exactly right, and that's not infrequent down here, is it? I mean,
Nope.
Because by default, that's the way it works. And those are the ones that we worry about the most, because who's going to help make the transition for them?
Yes.
We don't want to be in an emergency in which the 911 is called because the neighbors are alarmed. We need to go before that. We need to transition them before that. One of the things I wanted to mention, and it's in respect to this, all conditions that lead to dementia, in other words, all conditions in which the brain begins to fail, impair the ability to have insight. So this now damaged brain can no longer appreciate really what's going on as well as those around us. And therefore, patients with dementia with Lewy body don't notice the big differences that other people do notice around them. And it's difficult to convince them that things are changing, because from their point of view, at times, they're fine. So what are you bothering me for, type of thing? And that becomes a difficult challenge.
Can they be dangerous, though? I think you talked about a little bit. Can they be dangerous to themselves and to family members?
Yes, they can. Yes, they can. As the condition progresses, it's interesting. At the very, very beginning, we don't think so. As it progresses, yes, because they're still strong enough to act, but impaired enough to act irrationally. That's the worst time. As the condition goes beyond that, then they are no longer able to act on their wishes, and paradoxically, they're not as dangerous. It's that middle phase in which we're most worried.
And what about their eating? Do they stop eating? Do they change their dining habits?
They can't. They frequently have bizarre eating habits. Dementia with Lewy body patients, remember, have had now involvement of their frontal lobes and some of the limbic system, not to get too technical, but some of the driving efforts to appetite, some of the things that drive appetite are impaired. So not only do they eat less or more, but they eat different things that normally they did before. That's more in the dementia with Lewy body patient than even in the Alzheimer's patient. So that's another tip-off sometimes.
So I was just going to ask about that. So what we've been talking about is dementia with Lewy bodies. That's Lewy, and you said that was a scientist that discovered this?
Well, Lewy did the microscopic finding, yes, but the actual syndrome. This is what's interesting. Lewy bodies are initially described as the finding of Parkinson's disease patients. When you did a biopsy or an autopsy on a patient that died with Parkinson's, you found these things in the brain of those patients in the areas that Parkinson's hits the worst, which is the basal ganglia that have to do control with motor control. But then we began to see that other patients had it not just in the deep structures of the brain, but in the cortex of the brain. And we couldn't figure out why. Now, why should that be? Parkinson's doesn't affect that. And then we said, well, maybe it does. So now we realize that Lewy body disease, if you will, you can have this deposit throughout the brain. And depending on what part of the brain is injured first, the symptoms are a little different. So at the end, some patients with Parkinson's disease wind up being demented, and I can't tell them apart from patients that began as dementia with Lewy body and then become worse. So there is an overlap here, and that Lewy body is the microscopic finding in all of them.
I'll bet there are very few neurologists who have your amount of information. I'm very impressed with this. You're very enthusiastic in a sense. You look forward to really finding a cure, or let's say to finding a good diagnosis, don't you?
I am. It is an intellectual challenge that pays off. So I'm very excited about that. That I think we are in a good decade to be in the nervous system. 20, 30 years ago, not so much. Now, this is a good one. So I'm happy that I'm still practicing and doing this.
And let's go back to the clinical trial for a moment before we run out of time. How many weeks now will someone have to do this, and what does it require? They're coming in once a week. Would you explain that?
Well, not quite once a week. They do have to come in for it's best for them to think of it as a 5 to 6 month commitment, okay? And they come in every few weeks, at the beginning a little bit more often. And by the way, just because we don't want patients to worry about this, they are actually reimbursed for transportation, or we provide transportation. We don't want them to worry about any of that, okay? So they come in, we evaluate the patient, make sure they belong in the study. They then receive medication. We monitor them very, very carefully. We talk with the spouse or caregiver. We follow them very carefully. And after the 4 or 5 months, let's say, the study ends, and we hope to have learned something and then move on to the next study, which perhaps this same patient will be able to participate in.
This is wonderful. Oh, I just cannot tell you how much we appreciate this, Dr. Tuchman. And I want everyone to have this phone number again, 561-282-5546. Make sure you tell the person who answers the phone that you heard Dr. Tuchman on the radio with ANITA FINLEY, and they'll take you right in and see what they can do to help you. Thank you again, Dr. Tuchman.
Thank you, and thanks for getting the word out, because we need the community involved, and it's programs like yours that get it done.
We'll help you all we can, Dr. Tuchman.
Good
luck. Okay, bye.
Bye.